to all of you. Welcome to the GMO Academic Hour program. Today's topic for discussion is rational use of antibiotics in primary care. So we have invited Dr. Sumudu Suranadee. She is a senior lecturer in the Department of Medical Microbiology and Immunology of Faculty of Medicine, University of Colombo. She obtained her MBBS degree in 2005 with second class upper honors from the Faculty of Medicine, University of Colombo, and was appointed as a lecturer in the Department of Medical Microbiology and Immunology of Faculty of Medicine, Colombo. She completed her MD in medical microbiology and postgraduate diploma in molecular biology from the UK. Her research interest is on antibiotic resistance, and she is a member of the National Advisory Committee on the Antimicrobial Resistance and the National Action Plan Implementation Strengthening Team of the Ministry of Health, Sri Lanka. So let me warmly welcome Dr. Sumudu Suranadee for the Academic Hour program today. So if you have any questions related to use of antibiotics and rational use of antibiotics, please send them over through the chat box. We can attend to those questions at the end of the lecture. Over to you, Dr. Sumudu.
So this is going to be a sort of overview of this rational use of antibiotics in primary care, which is a very timely topic. So let's see why this topic is very important. So the outline of my presentation or the talk today would be, I will be first briefly discuss about the background of the topic and a few definitions which are going to be useful for you, and then the factors to consider when selecting an empiric antibiotics. How would you select an antibiotics? This is going to be a very sort of practical approach. Then some tips about rational prescribing, and at the end there are some case studies which we will go through together and see how to sort them out and what went wrong and things like that. So here in this presentation I will not be discussing like very theoretical stuff. So this is going to be a very practical approach to this burning issue. Okay, so first of all, so what is primary care? What do you mean by primary care? So primary care is when a patient meets the doctor patient meets the doctor for the first time. It may not be the first visit to the hospital, maybe a chronic patient visiting over and over again, maybe the first visit. It could be something like this. This is like I have shown here the first picture, brand new OPD. So it could be OPD setting in a big hospital, in a private hospital, or maybe a very rural setting where I have shown in the second picture here. Or in a completely different settings like this. So don't forget that now the patient care is not limited to hospital. It has expanded so much. Now we have ambulatory care like this. Of course, this picture is not a Sri Lankan picture, it's from a neighboring country where the doctor goes to the patient. And this is of course a Sri Lankan picture where this is a community clinic. And I know we have a GP surgery network in Sri Lanka, although it is not very regularized in the Western setting, but we do have a GP surgery network that is also that is of course primary care. So these are few examples for primary care. And what is rational use of medicines? This is not just antibiotics. This is for all medicines. So rational use is that we have to make sure that the patient receives appropriate medicine for their clinical need in appropriate doses in adequate period of time and the lowest cost to the community and to the patient. This does not mean that it is the cheapest antibiotic or the cheapest medicine. Cheapest does not mean it's the low cost. It has to be the low cost as well as a reasonable quality. So lowest cost does not mean the cheapest. So this is rational use. So every medicine or every medication has to be used rationally. When you prescribe even a paracetamol, a simple analgesic or anything, you have to think rationally whether the patient needs this medicine. That's the kind of golden rule in our practice. But why are we talk about antibiotic so much? What is this big fuss? What is the reason behind this fuss? So this is the reason, the antimicrobial resistance. So what is antimicrobial resistance? Now if you take another condition where we condition like diabetes, it's only the host or the patient you have to deal with. There is patient, the patient has diabetes, so we have to select an appropriate drug for the patient. So most of the time the patient will be on that drug for a very long period, most of the time for the lifetime, and most of the time you don't have to really change that drug. Okay, but in infections it's not like this. There is another party involved, which is the microorganism. It could be a bacteria or a fungi or a virus or a parasite. So it's the third party. So you have to think of this third party as well. So these bacteria, especially bacteria and viruses, they are very smart. So they can so I have shown here in their genetic material. It's not very complex like ours. So they have this ability to mutate very fast. So when we give antibiotics, so what they do is they try to survive in this hostile environment. So the few smarter ones, they will develop resistance to whatever the antibiotics we give them. So the weaker ones who are not resistant, they will die off. The smarter one who develop resistance, they will survive. So that is how all this antimicrobial resistant problem arises. So this is I have just shown the timeline of the antibiotic or antimicrobial development plus the development of antibiotic resistance. So if you can see, now here in 1940s we have the humankind, mankind developed penicillin, beta-lactams, and we have celebrated it so much. But if you at the same time in the 1940s, at the same year, another research group, actually not this particular research group, they have described the penicillinase, the enzyme which destroys penicillin, the penicillinase development by a group of bacteria. So whatever we produce, the bacteria also, they have counter-attacked us. So we have produced macrolides, so the bacteria develop macrolide resistance. We have produced methicillin, they develop methicillin resistance. That the battle like goes on. This is a never ending battle. Now if you clearly, like if you closely look at this side, you will notice another thing. Now in early from 1940 to 1960, you would notice that we have developed lot of new antibiotics. Okay, after 1960, the pipeline is dry. No new antibiotics. The reason is the companies, now these are developed by the private companies. They don't really want to invest on antibiotics because it's a loss. You develop antibiotics, after about few months there is resistance, so your antibiotic is useless. So you don't want to invest millions and millions on a drug like that. But if you develop an antihypertensive or anti-diabetic or some drug for hair loss or something, the person also the patient will also be using it for maybe 10 to 20 years, and there is nothing called resistant in those drugs. So it is more profitable to develop drugs for chronic disorders than antibiotics. So we are in a very, very, very dangerous situation now when it comes to antibiotic resistance and antibiotics. So next time when you go to wards, especially if you are working in ICUs, you would see sometimes you get culture reports. When you go through the antibiotic sensitivity, the isolate is resistant to all the available antibiotics and you have no options at all. So what are the reasons for antimicrobial resistance? It's overuse, not just human. We use antibiotics in animal husbandry, in agriculture, so all contribute to this, because when we use in animals, they also have microorganisms in them, so they develop resistance, and those microorganisms they can transmit to humans through the food chain. Inappropriate use by both healthcare workers and patients, this happens a lot in countries like us. Then subtherapeutic doses. If you give antibiotics, you have to give the correct dose. There is no point of giving subtherapeutic doses, very short courses for the sake of giving it. It also promotes antibiotics. Then the most important one we always neglect, poor quality antibiotics. So poor quality drugs, when you give a poor quality drugs, it will not produce the desired levels in the tissues, in the patient's tissues. So what will happen if I go back to this? So this will be promoted. So you have subtherapeutic level in the patient's tissues. So that subtherapeutic levels are not enough to kill these bacteria, all the bacteria, especially these smarter ones. Then they survive and then the patient will end up in this stage. So that is why we should not develop or we should not promote developing subtherapeutic levels in patients' tissues. So, or subtherapeutic doses and poor quality antibiotics. We have to avoid these two always. Okay, so what about the Sri Lankan situation? So we all know, if you ask from your colleague or when you think, we all know that we overuse antibiotics. So I have, this is one of the articles which I could find. So it says in acute respiratory tract infections, so we know acute respiratory tract infections, most of the time those are due to viruses. Okay, very rarely you get, I can't say very rarely, it's less commonly it's due to bacteria. So more than 70% of the patients received antibiotics in OPDs for acute respiratory tract infections. Okay, so this is unnecessary. So this is by misuse by healthcare workers in Sri Lanka. So if you go through this, we have to we have to understand our clients as well. So what patients think about antibiotics. So in this paper, this describes nicely how our patients think about antibiotics. Patients sought quick resolution to their ailments and frequently visited several private physicians to obtain a satisfying answer. So this is what happens if you don't give, if you don't prescribe drugs, or if you don't give antibiotics in Sri Lanka. So they are not happy with you, so they will maybe on the same day or next day they will go to another doctor. Okay, then self-medication was also common. Patients reused prescriptions for antibiotics, kept antibiotics for later use after prematurely stopping their course of treatment, and bought over-the-counter antibiotics. So these all are wrong practices. So yes, we will discuss this later. So then about the knowledge, some things paracetamol, as they think it's an antibiotic, and yes, most of the patients here also, this paper also says, they keep and reuse the antibiotics prescribed, maybe for themselves, maybe for someone else in the family or a friend. So okay, that's little bit that is little bit of the background about the problem. So next is, let's see, now most of the time when a patient comes to us, we have to start empirical treatment. So how do you start empirical treatment, or how do you start an antibiotic empirically? So we have to do this, but we have to do this intelligently, not just blindly. Okay, so what are the factors that we have to consider when selecting an empiric antibiotic? Okay, so when we were interns, I could remember, when I was intern, I can remember I had a list of antibiotics. So if it is upper respiratory tract infection, these are the antibiotics I prescribe. If it is a lower respiratory tract, these. If it is a UTI, these are the antibiotics. I don't know whether that list is correct or wrong. So that's how I practice, but that is completely a wrong practice. Okay, so this is how you should start empiric antibiotics. So first you have to think of the site of infections and the likely organisms. So one example I have given here, catheter-associated bacteremia is always, it's a result of staphylococci which are on the skin. So the thing is, now most of you may not remember this. You might have learned this in the medical school long time ago. So you might not remember this. So we have guidelines for this. Okay, we have guidelines for this. So always please go to a guide. If you can't remember, so if you get a patient with UTI or something, please go to guideline and look what is the best antibiotic. Then sometimes patients might come. So you might have a little bit of a prior knowledge about the patient's condition. So patients might come with for an example, cellulitis. So patient is MRSA positive, methicillin resistant Staphylococcus aureus positive. So then you have a hint. It could be due to MRSA. So there is a tip there. Okay, we may not be 100% correct. And then the most important thing, the local resistant patterns and antibiograms. So what you prescribe for sepsis in Sri Lanka, it's completely different for what you empirically start in the UK, because we have completely different antibiograms and antibiotic resistant patterns. Okay, what you give for sepsis in an urban setting like NHSL, it's different what you give in a peripheral hospital, because the antibiograms those are different. So ideally we have to have our own local antibiogram. So we are working on this, microbiologist. Maybe we will be able to materialize this in maybe another 1 or 2 years. Then the third thing is the patient's condition. So patients with infections, they come with their condition, it's differ. There can be a spectrum. Maybe very mild infection, simple UTI or a pneumonia, mild, they are stable. So you have all the time to start a narrow spectrum antibiotic, do cultures, and you can have time to think. You can send the patient home, get them back again the next day and review. But some comes with severe sepsis, very bad, the vitals are not good. So then you have to start a broad spectrum antibiotic and then narrow down later. Of course, then with other drugs also you have to think of PK/PD and allergies and things like that. So here now when you are managing the patient, you start empirical antibiotics, but before starting antibiotics, don't forget to get cultures. Then with the culture reports, please revisit, and then we can do the definitive or target treatment with the culture results. So this is the this does not happen most of the time in Sri Lanka. So we don't do cultures. We have many reasons for that. One is the bacteriological services or the microbiological services are not freely available, may be expensive, especially in private sector, and in government sector you have a huge caseload that you have to clear within a given time, so you don't have time to do all this. But remember this is the ideal way of doing it when you are managing a patient empirically. Okay, then how to this antibiotic, the next week thing is antibiotic stewardship. I will talk about that later. So next I will talk about a few things, recommendations for doctors who prescribe antibiotic in outpatient settings. So I have taken this recommendation from this publication. So if you are interested, you can go back and read. So these are very practical sort of points which are going to be very useful when you are practicing. Okay, the number one, so this is very simple. Use antibiotics only when needed. Okay, so when you are prescribing an antibiotic, you have to always think twice whether this is really needed. So we did a small study some time ago and we went through some of the GP prescriptions, and we noted that more than 70% of the prescriptions had at least one antibiotic, and some prescriptions had very broad spectrum antibiotics like levofloxacin. So we really couldn't think of why a patient who comes to a GP setting needed something like levofloxacin. So, and it's I think, I don't know whether you know it or not, levofloxacin is a drug we use as it's a second line TB drug. So it's a precious drug, especially in a setting like this. So it's very important when you are starting antibiotics, think twice. So most of the time in primary, patient comes with upper respiratory tract infections and viral diarrhea to primary care settings. So we know upper respiratory tract infections and watery diarrheas, they are due to viral infections. So they don't need antibiotics. But what we have to do here is we have to tell them, or tell our patients that you don't need antibiotics for these conditions, and we have to educate them how to, what they can do for their condition, maybe antibiotics, antihistamines, or something like that. And you should not start antibiotics, or we should not start antibiotic to prevent infection, to prevent secondary infections. Okay, some start antibiotics for viral upper respiratory tract infections to prevent pneumonia or prevent bacterial lower respiratory infection. So that will not work like that. So if you start antibiotics for viral upper respiratory tract infections, patient anyway, if the patient is predisposed to develop pneumonia, that patient will develop pneumonia with an antimicrobial resistant organism. So you can't prevent infections like that. So what you can do is you just follow up the patient. If they develop pneumonia, you treat for the pneumonia. Okay. Same with post surgical patients. So post-surgical prophylaxis, there are clear guidelines. You don't start antibiotics just to prevent post-surgical infections. Okay, so if it is not indicated, so I have written here, do not use to prevent infections or as a preventive measure unless it is clearly indicated. Okay, so if it is not clearly indicated, we don't use for the, to be on the safe side. Sometimes you write, you write all the, like a patient comes with upper respiratory tract infection, you give antibiotics, antihistamines, nasal decongestants, and you ask them to, take some Kothamali, steam inhalation, this and that, and to be on the safe side, you write antibiotic. So we don't do that. Okay. So second thing is, so if you decided to prescribe, you have to give what is adequate. Okay, so community acquired pneumonia, aminoglycoside, one example I have given here, it is not adequate. Community acquired cystitis, ceftriaxone, it is too broad, too much. Okay, so you have to give what is adequate for the infection. Sometimes we try to avoid some antibiotics because we are scared of maybe side effects. So, but if we anticipate side effects, we have to educate the patient, but we have to start that antibiotic if you think it is needed. Okay. Then pharmacodynamics and pharmacokinetics also we have to think of. One example I can give you is if there is a tissue infection like cellulitis, then we have to give something which penetrates tissue. Okay, so this is where these guidelines will help you to select one, and the shortest possible course will help you to improve the compliance. Then how to ensure patient's compliance and how to make the patient happy at the same time. So and the communication, so we have to ensure that patient understood the prescription, something like that. When you are dispensing, make sure that patient understand the indications. Now here, like this happens because of the lack of facilities. So now these drugs are given to a patient, but nothing is written here, so we don't know for what they are given. And especially the doctor or the nurse may have describe it when they are dispensing or the pharmacist may have described in their dispensing and the patients, but they forget that there are 6 different types of tablets, so they forget. So here also it's not very well written. So what we must write we have to give them a nice prescription, well written, okay, and then when you are dispensing, make sure that you clearly write how to take it, like, you know, the dose and the name of the drug. If they go to another doctor, then that doctor knows what the patient is on, okay. And simple things like scheduling the doses according to their activities. So if a school going child or someone who goes to work, a professional, so how to schedule their doses according to their activities. And elderly, pill boxes, and you know, these young people, cell phone alarms. So those kind of things, those will make the patients happy also. And when you're selecting also, you can select the drugs which are given twice a day or once a day to make them improve the compliance rate. But please don't use broad spectrum antibiotics just because they are once a day, like, or twice a day, like levofloxacin, okay. So there are antibiotic combinations, and you can always combine antibiotics also, but don't combine just in case. As I said, sometimes you try to, you know, combine something which covers gram-positive, negative, anaerobes and everything. So it's not a good thing. It will promote the resistance. So most community acquired infections, single antibiotics is more than enough, okay. Yes, this is something we have to work together. So this is like, you know, you can't stop this as an individual. But we have to work together. Low quality substandard drugs are very, very dangerous because they, as I said, they produce subtherapeutic levels. So it's our responsibility, as everybody is responsible for that from top to bottom, that we have you know, decent quality drugs in our country. So this is also very dangerous. Sometimes people self-prescribe. I have seen myself. Sometimes they get advice from friends. We also always get requests from friends saying that mata hembirisa and this and that, I have this, that, can you just WhatsApp me a prescription? So it's a very frequent request. So it's also a bit dangerous. We don't see the patient, we just, you know, over the phone we send them a prescription, and over the counter they come to the pharmacy and tell them, I have this, I have that, so give me an antibiotic. So this is very dangerous, but this is also, we can't stop this as individuals, but this has to be stopped by rules and regulations. We have rules and regulations in the country, but the implementation is the problem. So then what we can do as individuals, stay updated, and you only follow evidence-based guidelines. Okay, so now Sri Lanka, we have a little bit of problem because we didn't have guidelines, okay, with good guidelines, and the access is also another problem. So this is little bit of advertising also. Sri Lanka College of Microbiologists, we have empirical empirical and prophylactic use of antibiotic guideline, which was published in 2016, and we are reviewing it at the moment. So this will be the reviewed new edition will be available very soon. So this time this will be hopefully available as an app. So you can download this to your cell phone and you can use it. Okay. So this is something much needed and something we didn't have up in the past. So this will be available very soon. But if you like, this is of course a bit old, but still if you want any, like, if you want to go through, you can always go to this website and see. And there are so many other important publications related to microbiology in this website, so you can always go to this website and read. So then the other thing is, please use the clinical microbiology lab. So they are supposed to, now most of the big hospitals have a microbiology lab, and there are microbiologists, and so they are supposed to do diagnosis for you. And now the thing is, now you are in different specialities, and you have, you may have passed out long time ago, so you may not remember sometimes what sample to send. So what test to be done, how to send a sample, in what conditions. So if you can't remember, ideally we should have a guideline for this. But if you can't remember anything, please ring them and ask. Even if you can't remember how to take a urine sample, how to collect a urine sample, please don't hesitate. So it's their job to educate them and assist them. So please ring them and ask how to take this sample, when to collect it, and how to transport it. Okay. Then they have to advise, that's their job, advise on management, patient management, and stewardship. I will discuss what stewardship is, and infection and control. So take the maximum use of the lab. Yes, empirical, we have to prescribe empirically, but intelligently. That is the last one I want to discuss, but that is the most important one. So we have already discussed this. So what is antimicrobial stewardship? So it's antimicrobial stewardship. This is not a new concept, but this is a new concept to our setting. So this is what we do in stewardship. We do we develop a system to educate and persuade prescribers to follow evidence-based prescribing and evidence-based guidelines when prescribing antimicrobials. So here you might feel, now if you have a stewardship program in your hospital, you might feel that the person or the people who are governing this stewardship or who are doing this stewardship program is try to sort of control you or your antimicrobial prescription, which is not really it's not really the objective of the stewardship program. So what the main objective of the stewardship program is that the antimicrobials prescribed in the institution is done according to the evidence-based, it's done according to the evidence-based guidelines. So we have, in every stewardship program, we have a set of rules and regulations. So in Sri Lanka, at the moment, we don't have established stewardship programs, but we will be soon doing this. So there are I think one or two hospitals have already started pilot projects. So your hospital also might start a stewardship program in the future. So do we have any control over antibiotic prescription? Do we have any regulations in Sri Lanka? Yes, we do have. This is the circular which was published in 2016. Okay, this is called Introduction of Authorization of Prescribing Red light antibiotics. So this is from the Ministry of Health. So you can see now these antibiotics are classified as red light antibiotics. This is done by this is a WHO classification. So these antibiotics can only be prescribed, the clinicians can prescribe, but you need a microbiologist's authorization to continue these antibiotics. So you can see there are 15 antibiotics. So if you go through the list, levofloxacin is one of those, moxifloxacin, linezolid, so aztreonam, cefixime, cefoperazone, sulbactam. Okay. So, but this is a very old classification. So, the latest classification is this AWARE classification. This is also by WHO. So, here we classify antibiotics into three. A is access. So, these antibiotics, these are narrow spectrum antibiotics. These should be available in every hospital, anybody. The doctors can prescribe it, any doctor. Watch is high priority antibiotics. We don't prescribe them, haphazardly. Reserve are the antibiotics which are prescribed only by microbiologists. Okay, so this classification will be implemented to our system very soon, hopefully. So why do we have all this? Why do we need all these stewardship restrictions, all these things? Because we have a huge problem of antimicrobial resistance in our country. So yes, so that is all for the discussion. So let's move to this case. I will just read out the case. So, yes. So, previously healthy 16-year-old girl presents with dysuria and urinary frequency without back pain or fever. So, her UFR shows from clean catch samples has field full pus cells. So, if you are the OPD doctor, so what are your choices? What is your choice? You can start only one antibiotics out of 4. And for how long? So do we have answers? Not yet. Okay. Okay, so I will give you the answer. So this is a young girl. So we can assume that she doesn't have. Yes. That's a correct. Yes, correct answer. Yes, I'm very happy. So, yeah, very young girl, we can assume that she doesn't have any problem. So, yes, there's no back pain and no fever. That means that she doesn't have pyelonephritis, just a cystitis. And your UFR shows there are full pus cells. So, if it is a young girl, community acquired cystitis, we don't really need, if it is her first presentation, if it is not recurrent cystitis, we don't really need a urine culture. So yes, somebody said it's co-triamoxazole, very correct. Yes, correct. You can use something like not a very broad spectrum antibiotic, some co-triamoxazole or nitrofurantoin. So what about cefuroxime or co-amoxiclav? We know that nitrofurantoin, it may not be very very pleasant to take nitrofurantoin. Some people develop nausea and vomiting. Same with cotrimoxazole. People develop GIT side effects, and some develop severe skin rashes and things like that. But we know cefuroxime, when it comes to side effects, you hardly get side effects for cefuroxime. Very antibiotic with less side effects. Coamoxiclav is also the same. Some might develop a little bit of a diarrhea, but less side effects if they are not allergic to penicillin. So why not these two? The reason is both are broad spectrum antibiotics when it comes to UTI. Okay, so we don't want to give broad spectrum here. These two, especially coamoxiclav and cefuroxime, they promote antimicrobial resistance, resistant patterns like ESBL. So we don't want that in this 16-year-old girl. So we try to avoid these as much as possible. So duration, the shortest possible, maybe 5 days, not more than that. Okay. So let's move on to the next one. Now here the one learning point is you don't always need a culture. Okay, so you just can go with other investigations. Yes, this is another UTI story. 80-year-old woman with history of frequent UTIs was brought to the OPD by her son. So he noted that his mother is sleepier than normal and that her urine smells bad. So over the last year she has been admitted to the hospital 3 times for UTI and has had multiple courses of antibiotic. So during her last course of antibiotics, she developed severe diarrhea. So she has developed a severe complication. So severe diarrhea in an 80-year-old, it could be serious. Okay. So son is really worried and demands for antibiotic right away. So he also has a prior knowledge because he has last year she has had 3 hospital admissions and the doctors have given antibiotics, so he has some sort of an idea about how his mother should be managed. So bit of a difficult situation. So if you are the OPD doctor, would you prescribe antibiotic right away, or what can you do? So if you are in a hospital with some facilities, what can you do? So, do we have any? Not yet. Okay, now here, she has a history of urine tract infections, 8 years, on and off of hospital, 3 hospital admissions means that she is colonized with hospital flora. So you expect her to develop, if he has a UTI, it's most probably the organism probably would be a bit of an antimicrobial resistance one, not like in the previous case. Okay. So what can you do? Are you going to start antibiotics or not? So yes, there is no yes and no answer here. So what can you do is, if you are in a place with very good facilities, you can do a bedside test, something like a dipstick or UFR, and see whether she has features of a urine tract infection. If UFR shows feel full pus cells, then you can start antibiotics. Because the only symptoms is she is sleepier than normal and her urine smells bad. Okay, so you can do a simple test like that. Either a dipstick or a UFR. Okay, then what is the antibiotic you use? What is the antibiotic you are going to prescribe? So what you can do is you can go back to the history. So she has had 3 hospital admissions with urine tract infections. So you can go back and see whether they have done cultures previously. Because urine tract infection, you get urine tract infection from your own flora. Patient get from the patient's flora. Okay, you don't acquire it from another person, urine tract infection. So you can go back and look for any culture reports available. You can select an antibiotic according to that. Okay, according to that cultures, according to that antimicrobial sensitivity pattern. Okay, that would be the sort of ideal way of handling this patient. Okay. Okay. So we'll move on to the next one. So this is a real case I have seen. So yes, 85-year-old lady. So she did not have any others. I have seen this patient, so I know the history very well. She did not have any other comorbidities. I'm sorry, I couldn't include that in the history. And she was prescribed oral azithromycin for an upper respiratory tract infection. She has had cough, runny nose and fever. And on the second day, after she took tablets for, it was a 3-day course. On the second day, after she is taking 2 tablets, she developed severe epigastric pain and vomiting. She vomited continuously, and then she had to be admitted to a hospital to to manage this condition. So she was in the hospital for about 3 days, if I can, 2 days I can remember, and she was managed with IV fluids. So she returned home, and on the following day she developed fever, and then when they investigate, it was dengue. She was NS1 positive. Then they had to admit her again and manage in the hospital for she was in the hospital for another 10 days, and fortunately she was discharged without much problems. So if you go through this whole for the scenario, so this is not, I won't ask any questions on this, but we have lot of things to learn from this. So this is hospital acquired dengue. So this poor patient got this from the hospital. So we'll go from the beginning. So this patient, everything was started because she was given azithromycin for an upper respiratory tract infection, which is not indicated at all. So this is unwanted or misuse of antibiotics. So this shows the problems of misusing antibiotics. So unwanted complications or side effects. Then it increases morbidity. Fortunately, there is no mortality here. So morbidity. Then increases healthcare costs. So what do you mean by healthcare? So this patient was managed in government hospitals, but that is also healthcare cost which we never realized. So 12 days of hospital stay with IV fluids and everything increases healthcare costs. Then she had to be looked after by her family. Then they lose the family members. They have to spend money and all for transportation and everything, and they can't go to work, and it's also there's economic loss there as well. So everything, I know, if you just Google the topic, the problems or the effects of misuse of antibiotics, overuse of antibiotics, apart of antimicrobial resistance, they will give a list, and everything is, I would say, it's there in this case. So this is a very good example of problems we encounter if we overuse antibiotics. Okay, so that is all I have today. So if you have any questions, queries, or any help regarding microbiology, antimicrobial resistance, you can always drop an email to this email address. And thank you very much. I hope this is helpful. And thank you for listening, and thank you very much, my friend Charuni, for inviting me. I thank again the GMOA for inviting me for this talk.
Thank you very much, Dr. Sumudu, for joining us today amidst your business. Thank you very much for the listeners for joining us today, and meet you in 2 weeks' time.